All right, so mental health. All right, so mental health can be a little difficult to define. If you ask different people will say it's this, it's that, it means this, it's this to me. Um, so, in general, people who function in everyday life in society, who carry out what we consider what society deems as appropriate behavior and who are able to adapt to issues that come into their life, good or bad, that have coping skills, society genuinely views them as healthy people. Um, those who fail to be able to fulfill those roles and carry out the everyday life responsibilities, or whose behavior is deemed inappropriate, society views as ill. Um, this might not be the way you see things, it might not be the way I see things, but in society, this is how things are viewed. Um, as far as a universal definition, the World Health Organization defines health as a state of physical, mental, and social wellness. So that's why, as the nurse, it's so important that we, different from the doctors, we treat our patients holistically, because we're taking care of every aspect of our patients. We're taking care of their physical needs, but we're also looking at their mental needs and making sure that they have everything they need to be successful when we put them back into the community, back in their environment, in their social atmosphere. In most cases, mental health is a state of emotional, psychosocial, and social wellness that can be evidenced by productive, satisfying relationships, interpersonal relationships with our friends, our families, our coworkers. It's also demonstrated when we demonstrate effective behavior, when we have coping skills to handle all of the issues that come up in life, when we have a positive self-concept about ourselves, and emotional stability. People can have very different views or interpretations of behavior depending on their values, their culture, and their beliefs. We all believe something different. The determination of mental health may be difficult. So there are many components that are influenced by various factors. So some of the factors that we look at are the individual. So what is their biological makeup? Some people are predisposed to certain mental illnesses. They have genetic components, okay? So anxiety, depression, alcoholism, drug abuse, things like that do show genetic components. So when we're looking at that, also at the individual, we're looking at their self-esteem. How do they view themselves? What is their capacity for growth? Some people are great learners and they're very open to constructive criticism, and it's very easy for them to grow. Some people are not. Some people, you want to think about, are they able to find the meaning in life? So I might be dealing with something that's very troubling or terrible. Maybe I lost someone. I may handle it completely different than a friend of mine will. Maybe I am able to, although I'm suffering with something, I'm still able to look past that and realize that there's more meaning in life. This is just a difficult time. Not everybody's capable of doing that. And then we look at that emotional resilience. So how can they bounce back from something? What kind of a road have they traveled? Are they at the end of their rope, or are they still able to travel on and find the good in things and know that it will get better eventually? Then we look at interpersonal. So these are our relationships. So do we have effective communication? Do we have the ability to even help others? Can we communicate at work with our coworkers and our bosses? In our personal life, how do we talk with our children and our parents and our husbands? Do we even have that? Do we have a sense of belonging? Are we part of that family unit? Or are you part of anything that makes you feel like you belong? And then what are your coping abilities? Not everyone has coping abilities. I know that sounds strange and a lot of people don't think that, but some people just don't have them. And when they don't have coping abilities, that's when you start to have other issues. When you don't have coping abilities, you start turning to other things to cope, drugs, alcohol, things like that. There's a direct correlation with alcohol abuse, drug abuse, and a lack of coping abilities. Then we look at social and cultural. So what's your environment? So do you even have access to adequate resources? Mental health illness is a huge problem in the United States. Our communities are not set up to handle the mental health problems that we have. There's a lot of people that need help, especially when it comes to drug addiction, alcoholism, and stuff like that. They don't have access to adequate resources, which makes it worse. And then you want to look at, do they have a realistic view of their world, and what is their intolerance of violence? Where do they live? What kind of things are they dealing with? What kind of role models do they have in their life? So there's a lot of issues, a lot of influencing factors that go into a person's mental health. It's very multifaceted. So mental illness includes disorders such as depression, schizophrenia. There's a couple anxiety disorders, and then we have addictive disorders. And all of these illnesses are going to have an effect on our mood. It's going to have an effect on our behavior and the way that we think. Mental illness can cause significant distress. It can cause impaired functioning. Individuals do experience dissatisfaction with their self. It causes problems in their relationships, and it causes ineffective coping. Just our daily life, getting up every day, getting a shower, having to show up somewhere and be accountable to someone or somebody can seem extremely overwhelming, and for some people, even unbearable. And some individuals may even believe that their situation is hopeless. They can't see past what they're dealing with today. They are not able to look ahead and say, I know that I'm just in a really bad spot, but this is going to pass. I have a good support system and better times are coming. They're not capable of seeing that. And then there is always the ongoing debate among healthcare professionals that is it illness or is it bad behavior, especially when it comes to alcoholism and drug abuse. I work in a hospital, obviously, and we get a lot of patients that have alcohol problems and drug abuse problems. And I've heard a lot of my coworkers make comments like that. You know, it's a choice, it's this and that. And that's a whole nother conversation that we'll have. I could talk about that for hours, but it's really not just bad behavior. It's a lack of coping skills. You know, it's some genetic components. But that is a debate among healthcare professionals and other people that aren't even in the healthcare field. All right, so factors that contribute to mental illness can also be viewed within, wait a minute, that's the same one. Why is that thing here twice? That's the same thing. Sorry, I don't know why that slides in there twice. All right, so when someone is diagnosed with a mental illness, obviously it has to come from a professional. There is a general criteria that a person has to meet to be diagnosed with a mental illness. So they have to have dissatisfaction with certain characteristics about themselves, their abilities, and their accomplishments. So, you know, feeling like they don't have a lot of patience. They have a bad temper. They're not organized. They just can't get up in the morning and go to work. They're not living up to their potential. Things like that. They have to have ineffective or unsatisfying relationships. So whatever's going on in their life is spilling over into their relationships, whether it's with their loved ones, their friends, or in their workplace. They often have dissatisfaction with one's place in the world. They don't know where they fit. They don't know where they belong. They have ineffective coping skills with life events, even good events, especially bad events, loss of a loved one, loss of a job, issues with their children. And then they usually have a lack of personal growth because they're not able to move forward. They're not able to take into consideration what's going on and move forward in their life. They don't have to have all of these, but these are the general criteria. These are the things that we see. So we have something called the Diagnostic and Statistical Manual of Mental Disorders. In short, in the workplace or in the hospital, you'll hear it called the DSM-5. It's a taxonomy that's published by the American Psychiatric Association. It describes all mental orders. It outlines very specific diagnoses and diagnostic criteria to help healthcare professionals to help guide their assessment of patients. It helps them identify nursing diagnoses, and it also allows them to be able to plan, implement, and evaluate care for their patients. It is completely based on clinical experience and research, and all the mental health clinicians who diagnose psychiatric disorders use this diagnostic taxonomy. Again, its purpose is to standardize nomenclature or language for all healthcare professionals. So all healthcare professionals that work in a mental illness field, we want them to be similar in the way that they speak and talk about the illnesses the same way. It does assist them in identifying underlying causes of disorder. So that way, if they can figure out what the underlying cause is, then they're going to be able to help their patients be more successful in treatment and find medications that can help them. And then it helps understand the client's psychiatric mental health medical diagnoses. So they have a couple different classifications. They have major psychiatric disorders. Some examples of those are depression, schizophrenia, anxiety, and substance-related disorders. So alcohol, drug abuse, things like that. Then we have medical conditions, which could be relevant to managing and understanding a person's mental disorder. And then psychosocial and environmental problems. So these are problems with the primary support group, their social environment, their education, their occupation, housing, economics, whether or not they even have access to healthcare, and then lastly, the legal system. So some historical perspectives on mental health. Back in the ancient times, excuse me, sickness at that time indicated a displeasure of gods. It was viewed that if you had a mental illness, that you were being punished for your sins, you were a bad person. You were viewed as demonic or divine. The divine people were worshipped, and the demonic people were ostracized, punished, and then they even burned them at stake. Aristotle attempted to relate mental disorders to actual physical disorders. So he developed a theory that the amount of blood, water, yellow and black bile in the body believed to control all of our emotions. The four substances or humors that they called them corresponded with happiness, calmness, anger, and sadness. If there were any imbalances in the four humors, that's when they believed that it could cause mental illness. Treatment was geared towards balancing or restoring the four humors, and they did that by bloodletting, starving the patients, and then purging them. We've made a lot of advancement in mental health, thank God. Early Christian time, they believed that all diseases were blamed on demons and that all of the mental ill people were viewed as possessed. They had priests that performed exorcism to get rid of the sufferer's evil spirits. Then the period of the 1790s, this was viewed as a period of enlightenment. They created asylums for our mental health patients. It was viewed as a safe refuge or a haven, which could offer protection at institutions where people had been whipped, beaten, and starved because they were mentally ill. So Dorothea Dix, I know you guys remember her from Fundamentals, right? We talked about her the first week. She began a crusade to perform the treatment of mental illness for patients. She really advocated for all of the mentally ill patients. She eventually went on to open 32 state hospitals that were able to offer asylum to people suffering with mental illnesses. She advocated for them. She made sure that they had adequate shelter, that they were given nutritious food, and that they had warm clothing. Sigmund Freud, he had a scientific study of diagnosis and the treatment of mental illness. He studied the mind, the disorders, and their treatment as no one had ever done before. He was remarkable. Freud challenged society to be able to view human beings objectively.
Mrs. Davis, can you let Shanoa back in? She said she got kicked out.
Yes. Yep. Okay. So in the 1950s, that's when we saw the development of certain psychotropic drugs. So for the first times, they were able to distribute drugs to patients that were helpful with reducing agitation. It helped diminish psychotic thinking, and they started helping with depression. Once we started introducing these psychotropic drugs, we started seeing shorter hospital stays for patients, and people became well enough to go home because we were able to manage their symptoms in the community. The first drugs that were developed is Thorazine. This is an antipsychotic drug, and lithium, which is an anti-manic agent. And then in the next following 10 years after that, we had the development of Haldol, and then the benzodiazepines, anti-anxiety drugs, and then those MAOIs, which help with antidepressants. So we also had a community mental health movement. This was geared towards treating those with mental illness in a less restrictive environment. So instead of having them in hospitals all the time, we wanted to be able to now, with the addition of these, the development of these medications, really wanted to keep these people in their community settings because they believed that they would be able to have a better opportunity of getting better if they were surrounded by their loved ones, their family, friends, and if they could still continue to go to work every day. So we had this huge push to have a community mental health movement. So we saw deinstitutionalization, which, like I said, is a shift from the institutional care in the state hospitals back into the community facilities. They served smaller geographic areas and provided less restrictive treatment closer to the individual's home so they could be around their family and their friends. Community mental health centers were able to provide emergency care, inpatient care if needed, definitely those outpatient services. They could do partial hospitalization, screening services, which is huge, and then also education, which we know is just as important. So then we started to see legislation for disability income. So Social Security Disability Income, SSDI, Supplemental Security Income, SSI, was developed and allowed people with severe and persistent mental illnesses to be more financially independent because they viewed that mental illness is now just like a medical disease. It keeps you from being functional, making money, being able to pay your bills. So they also saw some changes in the commitment laws. They made it more difficult to commit people for mental health treatment against their will. It is still possible to do that, but we've changed things so that it's not as easy as it once was. So mental illness in the 21st century, where are we at today? So according to the National Institute of Health, in 2018, there were 44.7 million people in the US to have a mental illness. Only of those people, only 19.2 million received treatment within the past year. That's a huge population of people who are still suffering with mental illness that aren't even being treated. People 18 to 25 years of age have the highest prevalence of mental illness and the lowest percentage of people receiving treatment. More than 18.6% of Americans aged 18 years and older have a diagnosable mental disorder. 20.7 million have a substance abuse disorder, and 8.4 million of this population have a dual diagnosis. There is a huge correlation with patients who have drug addictions, alcohol addictions. You always find them in this dual diagnosis program because they don't just have, there is an underlying issue there which causes them to end up this way, unfortunately. So we see them enrolled in a lot of these dual diagnosis programs. Serious emotional disturbances can impair daily activities. Like I said, just being able to get up out of bed every day, going to work, having to show up for your family, take care of your children. for an estimated 15 million adults and 4 million children and adolescents. It is also an economic burden. Both healthcare costs and low productivity exceeds all of the types of cancer. So that's important. You guys need to know that. You're going to see that somewhere, probably on a test. Mental illness is a huge economic burden. It exceeds that of all the types of cancers financially. Whoops. It is the leading cause of disability in the United States and Canada for those ages 15 to 44. There is an increasing number of both adults and children and adolescents that are being treated for mental illness, yet only 1 in 4 adults and 1 in 5 children are treated. That's a lot of people that still are not seeking treatment. Treatment is still lagging in our homeless population and in those with substance abuse problems. When we talked about deinstitutionalization, we saw negative effects and positive effects. So we started seeing what they call a revolving door effect. So people with severe and persistent mental illnesses have shorter hospital stays, right? Because we've come up with these medications, we treat them on the short spectrum, and then we put them back into the community. Can you guys hear me? Because it says my internet is unstable. No. Can
You
hear
went
me?
out for a little while, but you're back now.
Okay, thank you. So because they don't stay longer in the hospital, and there's a couple things that contribute to that. Insurance companies, who's paying, things like that, all contribute to how long you stay in the hospital. But because these people usually have shorter hospital stays, then we see them coming back to the hospital more frequently. There's a continuous flow of clients being admitted and discharged quickly, which usually does tend to overwhelm our general psychiatric units on our hospital. ED visits in some areas have increased by 400 to 500%, which is huge. And these patients are often what we call boarded in the emergency room while they're waiting for inpatient beds. This leads to frustration of not only healthcare personnel, but it causes dissatisfaction with care for clients and their families. And some believe it also has a increase in the risk of someone committing suicide, because if they feel like they can't ever, if every time they're having a nervous breakdown or they're suffering in some type of a crisis, if they feel like no one's there for them or they don't have anyone to help take care of them and meet their needs like we should, then that starts to signal to, it makes them believe that it's hopeless and that they're not ever going to get any better and they don't want to continue this pattern of life. And then we put these patients back into the community. And like I said, our communities aren't designed to be able to take on the mental illness that we see. So we often kind of get them a little squared away in the hospital, but then we put them back in the community and there's no resources. So it's very difficult. There is an adequate number of psychiatric inpatient beds that could better meet the needs of clients and might even decrease homelessness, incarceration, and violence. So if we had more psychiatric beds and we could meet those patients' needs, things could be different. Now, where I work at GBMC, we have a psychiatric unit. We have 12 beds. 12 beds is extremely small. They're always filled. Whenever I have patients that need to go there, they can't go there. We always just have to keep them on the floor with us, even if they're on suicide precautions. So it's definitely, it's hard for everyone involved. So we're seeing those shorter hospital stays, decompensation in the community, and then they're coming back for rehospitalization. People that have severe and persistent mental illness may show signs of improvement in a few days, but they are not stabilized. You really can't fix someone's mental illness in 2 or 3 days. They're not what we would consider stable. We discharge them into the community without being able to cope with community living. And then, like I said before, many of those clients have a dual diagnosis of both severe mental illness and substance abuse. And substance abuse cannot be dealt with in 3 to 5 days during a typical admission. So what are the illnesses and concerns for mental illness and the 21st century? So homelessness is a major problem in the United States. Currently, there are 610,000 people, including 140,000 children, homeless on any given night. Approximately 257,300, or 33% of those people, have serious mental illnesses associated with substance abuse. 30% have associated physical illness or comorbidities. Homelessness worsens psychiatric problems for many people with mental illness who end up on the streets, contributing to a vicious cycle. So usually it is a mental illness that contributes to homelessness. People just don't usually wake up and choose to be homeless. There's been a mental illness that has caused a series of unfortunate events to develop without relationships with their family members. They lose their job, they become homeless, and then they don't have a good outlook on life, and it just continues to spiral from there. So it is just a vicious cycle. There is a lack of adequate community resources. And then inpatient psychiatric treatment still accounts for most of the spending for mental health in the United States. So they never have been given the financial base it needs to ever be effective. So something that you guys have heard over several times over the last 20 slides is that there's a huge correlation with mental illness and substance abuse, and that we don't have enough community resources to take care of the mentally ill in our communities. So what are our objectives for the future? So more people are seeking treatment for mental illness, but we still have large numbers that go untreated, people who are incarcerated. We see it with those people who have both mental illness and substance abuse issues, and then of course our homeless population. So Healthy People 2020 objectives. So if you don't know what Healthy People 2020 is, it is a science-based 10-year national objective that they set for improving the healthcare of all Americans. So they said by 2020, they wanted to be able to meet certain objectives. So for mental health, one of the goals was to increase the number of people that were identified, diagnosed, and treated so that we could help them live healthier lives. Another objective was to decrease the rate of suicide and homelessness. Wanted to be able to increase employment for those with serious mental illness, and to provide services for incarcerated people with mental health problems. So you can read more about that in your book. Box 1.1 talks about the Healthy People 2020 mental health objectives. So we're going to talk about community-based care. So we know we have a lack of appropriate number of community mental health centers to provide services for all the people that require it. We have developed community support programs. So of the programs that have been developed, their focus is on rehabilitation. We want to bring these patients in. We want to find out what their mental health illness is. We want to rehabilitate them. If we can get to the bottom of what is bothering them, we can rehabilitate their mental outlook. They will be more productive. Then we'll be able to look at their vocational needs, because now they can take on jobs. They're ready to function in society. Because now they can handle it. They're not so overwhelmed with their mental illness. So we're going to look at their vocational needs. We're going to look at their education level and see what do we need to do to help them move along so that they can be productive members of society. And then we look at socialization. You know, do they have the self-esteem to go out and make a resume and go on an interview? What kind of help do they need? And then of course, always the management of their symptoms and their medication, because some patients that have mental illnesses cannot go without their medication. It's a necessity. Community support programs were developed to meet the needs of people with mental illness outside the walls of the institutions. These community support programs are funded by each individual state, their local counties, and then also some private agencies when available. The quality of services, the quantity of services, what type of services you get are very different depending upon the state and the county. And then of course, what kind of financial backing they have. The community support programs are an accurate anticipation of the extent of people's needs. So they're not really prepared still with the programs that we've developed to handle mental illness to the extent that it needs to be handled. Despite flaws, there are positive aspects that make them preferable for treatment. Clients and institutions often lose motivation as hope, as well as functioning daily living skills. So if we can take care of people in their community, they are surrounded by their loved ones, their family members, they might still be able to go to work. All these things help motivate them, make them feel important, make them feel like functioning members of society, and it will ultimately improve their odds of getting better. So there's the managed care movement, which was developed in the 1970s. This managed care movement was designed to help control the balance between the quality of care that we provide and then the cost of the care. People at that time were receiving care based on need rather than on request. We had the development of utilization review firms and managed care organizations. This started in the 1990s. It's also called case management, and we still have this today. Case management provides necessary services to patients while hoping to contain the costs. In reality, expenditures are often reduced by withholding services that are essentially necessary or by substituting less expensive treatment alternatives for what they consider more expensive care, such as a hospital admission. But with the case management, what's nice is that when patients are discharged from the hospital, different insurance companies will follow them. They'll assign them a case manager, and then that case manager will have a group of, say, 10 or 20 patients that she follows on a weekly basis. So she's going to call, or she or he will call and check up on that patient. How are you doing? How are your medications? Do you need anything? So they're directly giving that patient the support that they need, but they're also, in a sense, preventing them from having that readmission to the hospital because they're managing their case on a weekly basis, day-to-day basis by checking in with the patient. And then we have the separation of mental health care from physical care for insurance coverage. So some policies actually placed an annual dollar limitation for treatment, while others limited the number of days that would cover. So this is something that we see with substance abuse. Most major insurance companies will only cover a 28-day stay for alcohol withdrawal or drug addiction. Some nicer insurance companies will pay up to 90 days. And patients that suffer with drug abuse or alcohol abuse, a lot of the times that they don't reach out and get help is because they can't afford it. So if they don't have a policy that covers it, it can be extremely expensive. I'm talking $30,000, $40,000 a pop, depending on where you go. Most people don't have that kind of money. So when you think about it like that, it makes it completely understandable why we have the issues that we have in society with alcoholism and drug abuse. So cost containment and managed care, mental health care management through privately owned behavioral health care firms that provide their services and manage their costs have been developed in the last 15 years. If no private insurance, you have to rely on the county of residence for payment. So what you see is a lot of these community-based outpatient treatment centers or 28-day inpatient centers will take you on what's called a scholarship. They'll bring you in, the company will get funds from outside in the county and pay for you to be able to go there for a certain day. Then we have healthcare finance administration. So this is Medicare and Medicaid. So remember Medicare, we care about the older people, right? That's how we remember it. This covers people 65 years and older, people with permanent kidney failure, and then patients that have certain disabilities. Medicaid, we're helping people that need aid. This covers our low-income individuals and family, and it is jointly covered by the federal and the state government. They both pay into it. And then we have what's called the Mental Health Parity Act. So this act eliminated annual and lifetime dollar amounts for mental health care for companies with more than 50 employees. so that no matter how much, they couldn't max out anymore, which made it good. So these people could continue to get the help that they need. However, substance abuse is not covered by this law, unfortunately. So when we talk about psychiatric nursing practice, we have Linda Richards. You guys might remember her from Fundamentals. She was the first American psychiatric nurse. She organized educational programs in the state mental hospitals where she lived, and she believed that the mentally sick should be at least as well cared for as the physically sick, that they were both equal. McLean Hospital in Belmont, Massachusetts was the site of the very first training for nurses to be able to work with people that had mental illnesses. The care was primarily custodial at the time. It focused on nutrition, hygiene, and activity, which when you think about this are important things for anybody that has any type of illness, whether it's mental or medical. But these three things, focusing on what you eat, taking care of yourself, participating in activities, these are things that some people that have mental illnesses can't do. So that was a great way to help start taking care of those patients. We saw an expansion of the role with development of somatic therapies. They developed insulin shock therapy, psychosurgery, and then electroconvulsive therapy. The very first psychiatric nursing textbook, which was called Nursing Mental Diseases, was published in 1920 by Harriet Bailey. She was a nurse. The Johns Hopkins School of Medicine was the first school of nursing to include psychiatric nursing course back in 1913. The National League for Nursing, which accredits various nursing programs across the United States, required schools to include psychiatric nursing experience. And then there were two early theorists who helped shape our psychiatric nursing practice as we know it today. One of them was Hildegard Peplau. She described the therapeutic nurse-client relationship. We're going to talk a lot about her. She wrote extensively about anxiety, interpersonal dimension, which was crucial to her beliefs, and forms the foundation of our current practice that we see today. There's June Mello, also a nurse. Her focus was on clients' psychosocial needs and their strength. The American Nursing Association, ANA, and the standards of care, they were developed to determine safe and acceptable practice and to access the quality of care. The American Psychiatric Nurses Association, APNA, also developed standards of practice and professional performance. They outlined areas of practice and phenomena that were of concern to them. They described the 13 areas of concern that mental health nurses should focus on when they provide care for clients. They developed the standards of care incorporable to incorporate the phases of the nursing process, including specific types of interventions for nurses that practice in psychiatric settings. And you can read more about that in your book on page 8, box 1.2. So psychiatric nursing practice, there are areas of practice for basic and then advanced nursing practice. So some of the basic level functions that we can do as nurses is we can provide some counseling. We can provide therapy in a milieu therapy, so it's like a setting with other patients. We can provide self-care activities, so really teaching our patients how to do things that will help take care of themselves. Physiobiologic interventions we can provide. We can do health teaching, case management, right? We talked about that a couple slides back. And then we can do health promotion and maintenance. Some advanced level functions, this would be providing psychotherapy, prescriptive authority for drugs. So this is going to be your nurse practitioner that's doing this. We can even consult and be a liaison for patients and with other providers. And then we can also evaluate patients. So those are your basic level functions and your advanced level functions. So students always have concerns about the mental health clinical experience. Now, I don't know if you guys are going to have clinical or not, but if you do, I'm sure you guys will have some of these valid concerns. So obviously this is a clinical rotation that is going to be different than any other previous clinical experience, which you guys haven't really had. You've only had one day, so you don't have a lot to compare it to, but it is very, very different. A lot of students worry about saying the wrong thing. There is no phrase that you could ever say to a patient that's going to completely fix them. Some of us think that they're going to go in and they're going to be actively listening and they're going to sit with the patient and be present, and that's going to help them. And it is going to help them, but it's not going to solve all of their problems and fix them. If it was that easy, we wouldn't have any mental health issues in the United States. Just as that is true, no single statement that you could ever make to them is not going to significantly worsen them. So it's not really possible to say the wrong thing. I mean, I guess it is, depending on what you say, but more than likely you will not say the wrong thing. A lot of students feel like they won't know what to do. So when you think about taking care of a patient with a mental illness, it takes quite a bit of time to really develop that therapeutic nurse-client relationship. It's not anything that really happens on the first visit in the first hour. It takes time, it takes trust, and you have to be patient. So we don't really expect you to know exactly what you're doing when you go in. Some students have fear of being rejected or that people won't talk to the student. So if this happens to you when you are in the clinical setting, it's not something that you should take personal. It's not a personal insult. It's not a failure. Some patients that have mental illnesses, if they are inpatient or they're outpatient and they're seeing the same practitioner or nurse on a weekly basis, they have that therapeutic client relationship with them. They feel comfortable with them. They feel trusted. They know that they're going to take care of them. They don't always want to open up with other people. It's not easy for us to talk about our problems with perfect strangers. So you shouldn't ever feel like you're being rejected or that they don't want to talk to you. Asking personal questions. So it's probably not the first thing you want to do when you meet a patient. Hi, Mrs. Jones. My name's Trish. I'm going to be your student nurse today. Tell me about all the bad things you've done in your life. Or you don't want to go in and start talking to them like that. You just want to talk to them and get to know them. What do you do for a living? Do you have children? Things like that, little conversations. Students are always scared about handling bizarre, inappropriate, or sexually aggressive behavior. So you need to understand first and foremost that we're not going to put you in environments where you're with patients who have killed people, committed murder, things like that. You might be in that general area if you're in like a mental hospital, but you're not going to be around those people. That wouldn't be safe for you guys. You might be around people who are schizophrenic, that hear voices that are talking to you. That can catch you off guard and it can seem very bizarre. So I guess you guys need to know that is something that you could be subjected to, but you just don't want to bring attention to it. You don't want to point it out. And if you're ever in a situation where you feel uncomfortable, you just want to go get your clinical instructor right away, or any other employee or nurse that's in that milieu area where you guys could be. And then it's important to monitor your facial expressions and your emotional responses. So if you are anything like me, I always say on my face exactly what I'm thinking. And it is something that I know that I have to work on. And I remember when I did my mental health clinical and I went to, I think it was Spring Grove, and they paired me up with a man. We each got like our own person to sit with, and I went and sat with him, and he was so nice. We had like this great conversation for like 5 minutes, right? And I was like, wow, this guy is like so nice. He's not saying anything off the wall, right? This is great. And then all of a sudden I saw him turn his head to the right and he started saying something, and I like looked over and there wasn't anyone there. And he looked back at me and he was like, just wait a minute. She just keeps telling me to kill you, but I don't want to kill you. And I'm like, okay, that's interesting. Well, I don't even know what my face looked like. I hope that I was professional, but these things do catch you off guard. And then for 10 minutes, this guy continued to have a conversation, and he was like getting very upset. And then he started cussing at the woman who was not there. And he was like, no, bitch, I am not going to kill her. I can't do that. I'm going to go to jail forever. And I was like, okay, this is too much for me. I'm going to leave. And then I felt uncomfortable. So I went and I got my clinical instructor. So you might see those things, you might feel uncomfortable, they might scare you, they might make you question a lot of things. All those things are normal. But the big take home here is that you're never alone. You're always going to be with your clinical instructor. And whenever you feel unsafe, you just go get another person, a nurse in the milieu, your clinical instructor, whoever else is around. They're all common concerns. Everybody feels like that. You do have to set limits and you have to maintain boundaries. When a client's behavior is sexually inappropriate or if patients are invading your space. So next week, we're going to talk more about maintaining boundaries, setting boundaries, how we do that. But we can do it respectfully and professionally when clients start to exhibit behavior that is not acceptable. If someone comes into your space and they get very close, it's very acceptable for you to back up and say, excuse me, you're getting too close to me. It's making me feel uncomfortable. If you want to continue this conversation, I need you to stay over there. I'm going to stay over here. So we're not being disrespectful. We're just being firm and we're setting limits and maintaining boundaries. And a lot of patients that have mental illnesses, they need those limits and they need those boundaries. You need to think about how you're going to feel, how you're going to handle feeling unsafe. Sometimes you feel like you don't have little or any. You need to understand that you don't have a lot of contact with those that are seriously mentally ill. We already talked about that. You're always going to be around staff members who are specifically trained to handle aggressive clients in a safe manner. They know these patients. They've been working with them day in and day out for a long time. They know what to expect from them. They know what they're capable of. When we do pair you up with patients, you do sit in that milieu environment. So it's that open environment rather than a closed room. So you are with other people. It is essential in mental health that the client's identity and treatment be kept confidential. So if you do go into the mental health facility and you happen to stumble upon a friend of yours, it is not okay to go back and tell other people you know that you saw them there. It is a confidential environment. You might be dealing with similar problems or backgrounds. So we don't know why some people have serious emotional issues and some people don't. We're also going to talk more about those factors that increase our risk for developing mental illnesses over the next couple weeks. So as with every other type of nursing care we provide, we as the nurse need to be aware, right? We have to practice self-awareness. In case you forgot, self-awareness is a process by which the nurse gains recognition of his or her own feelings, what you believe, and what your attitudes are about certain things. So when we become aware of ourself and our feelings and our thoughts and our values, we are better able to provide quality care to our patients. Everyone has a unique or a different value and ideal or belief, and everybody's idea is completely acceptable and it needs to be respected. You don't have to believe in it yourself, but we do have to respect that difference in our coworkers and our patients. There can always be a possible conflict between personal values and beliefs and those of the client. So the nurse, like I just said, does not need to condone the client's views and behavior. We merely just need to accept them as different than ours, and we cannot ever let them interfere with the care that we provide. We need to accept differences in each other, view each client as worthwhile, regardless of opinions or lifestyle. And then self-awareness is always attainable through reflection. And I think I've said this before. I spend a lot of my time practicing self-awareness and reflection on my way home from work. I have like a 45 to 50-minute drive, and that is when I look back on my day and I think about what went wrong, what went well, what I can change, how I want to grow, what could I have handled better. So when you reflect on the day and what you're learning, and even as the nursing student, that's why we have you do these reflective journals. You're really looking at your nursing practice, your student nursing practice, and realizing what you've learned, what you want to learn, what your strong points are, and what your weaknesses are. And when we're able to identify those, that's how we grow. All right, so hospitals, I got the answer up there. Hospitals were established by Dorothea Dix. Those hospitals were designed to provide what? Asylum for patients, confinement, a therapeutic milieu, or provide public safety.
A, public safety.
You said A?
County Fishermen Fund.
A.
A. Yes, A. Yep. Her hospitals were designed to provide an asylum for her patients. Yes. All right. Hildegard Pablo is best known for her writing about what? Community-based care, humane treatment, psychopharmacology, or the therapeutic nurse-client relationship.
D.
D.
A.
D.
A lot of different answers. I hear A, I hear B. The answer,
D.
oh, you said D.
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 Yeah.
D, yes, therapeutic nurse-client relationship. We're going to talk a lot about her over the next couple weeks. So I know this stuff is probably going to be boring, but we are going to talk about psychosocial theories and theory. So psychosocial theories, there have been various theories that have been developed by certain people in an attempt to help shed light or explain human behavior, health, and mental illness. Theories work to describe how normal development occurs based upon the theorist's beliefs who wrote it. And then it also describes any assumptions and the view of the world. So the psychosocial therapies have produced many models that are still currently used in individual and group therapy and in various settings. So a couple of them are the psychoanalytic theory, which was done by Freud. We have the developmental theory by Erikson and Piaget. We have interpersonal theory, which was developed by Sullivan and Pablo. We have the humanistic, which was by Maslow and Rogers, the behavioral theory by Pavlov and Skinner, and then existential, which was by Beck, Ellis, Frankel, Pears, and Glasser. So we're going to talk about these. So Sigmund Freud, he is considered the father of psychoanalysis. So he says that all behavior is caused by something and can be explained. He believed that human behavior is motivated by repressed sexual impulses and desires, and that late childhood development is based on sexual energy, which we call libido, as the driving force for that development. So there were a couple personality components to his theory. The first one was the ID. So this is the part of one's nature that reflects basic or innate desires, such as pleasure-seeking behaviors. So why do we talk about pleasure-seeking behaviors? So drugs, sex, things like that, aggression and sexual impulses. It seeks instant gratification. So when we talk about instant gratification, it means that we have to have it right now. We're not willing to work for it to get it. So when we think about sometimes with teenagers and they get that job and maybe they're saving money for something. Well, they don't want to save their money. They maybe, my son is 16 and he has a job and he wants to get a PlayStation, but he doesn't want to wait to save up the $500. So he's just going to settle right now and buy an older PlayStation because he needs that instant gratification. So it seeks instant gratification, causing impulsive, unthinking behavior, and it has no regard for rules or social convention. And then there's the ego. So that's the balancing or the mediating force between what we're going to talk about next, the superego and the ID. So this represents mature and adaptive behavior that allows a person to function successfully in the world. And then we have the superego. So this is the direct opposite to the ID. This is the part of the person's nature that reflects moral and ethical concepts, values, and parental and social expectations. So the ID, the ego, and the superego. So here's just a little cartoon. So this is the innate desires, the pleasure seeking, the aggression, the sexual impulse, right? And then that's the ID. And then the superego, right? This is our moral, our ethical, our values, our parental values. And then this is the ego. So our mature adaptive behavior. So he believed that the human personality functions at 3 levels of awareness. So he believed that there's the conscious, it's actually more than 3. It's the conscious, the preconscious, the unconscious, and the subconscious. So the conscious level refers to perception, so the way we perceive things to be, our thoughts and emotions that exist in us, in our awareness, such as being aware of being happy or feeling about how we feel about a loved one. Our preconscious refers to the thoughts and emotions that are not currently things that we're aware of, but he or she can recall them with some effort, such as an adult remembering what he or she thought or did as a child. And then our unconscious, this is going to refer to a realm of thoughts and feelings that motivates us, even though we are completely unaware of them. So these are our defense mechanisms, right? We respond a certain way to certain things and our traumatic experiences. So these cause us to do things in our life based upon these defense mechanisms and our traumatic experiences, and we don't know why we're doing them, but they stem from these issues. And then our subconscious. So this is believed what we do and say is motivated by our subconscious thoughts or our feelings. And then he also touched on the eco defense mechanisms. So these are methods of attempting to protect the self and cope with basic drives and or emotionally painful thoughts, feelings, or events. And it usually operates on an unconscious level of awareness. So, when we deal with things, about being defensive about certain things or handling certain situations, people don't usually handle things the wrong way just because they're trying to be difficult. It's a learned behavior because of something that's happened in their life previously. So it's just something that they have to work on, but it does happen on an unconscious level. They don't set out to do it. So he also believed that there are 5 stages of psychosocial sexual stages of development. So this is childhood development on the belief that sexual energy, which he terms libido, was the driving force of all human behavior. So the first stage, which is birth to 18 months, is oral. The next stage, which is 18 to 36 months, is anal. 3 to 5 years is phallic. 5 to 11 years, or maybe up to 13 years, is latency. 11 to 13 years of age is genital. You can read more about that in table 3.2 on page 44. And then he also talks about transference and countertransference. So transference occurs when the client displaces onto the therapist attitudes and feelings that the client originally experienced in another relationship. So your book gives this example here, which I put in the notes for you guys, about an adolescent female client who's working with a nurse who is about the same age as the teenager's parents. She might react to the nurse like she reacts to her parents. So she might experience intense feelings of being rebellious, and she might make sarcastic remarks to them. These reactions are based on her experience with her parents, but not actually with the nurse. So that's transference. And then countertransference occurs when the therapist displaces onto the client attitudes or feelings from his or her past. So if the nurse is taking care of a patient who is an active drug user at the time, and she herself had a child who was a drug addict, she might take on the feeling of disappointment with the client. Her motherly instincts might come out when she's providing care for the patient. So that would be countertransference. So transference is when the patient does it to the nurse. Countertransference is when the nurse does it to the patient. So current psychoanalytic practice today, so we do offer psychoanalysts for our patients. The focus is on being able to discover causes of the patient's unconscious repressed thoughts, feelings, and conflicts related to anxiety. So what happened in this person's life, whether recently or in their early childhood, what happened to them that's causing them to feel the way they do and act the way that they act. It focuses on resolving early conflicts, so things that happened in your childhood, because there is this belief that things happen early in our childhood that we don't remember. Some people can never remember them, traumatic events, things like that. Some people, through series and long-term rehabilitative therapy, can sometimes actually regain a remembrance of what happened. And then there's free association, dream analysis, so trying to find meaning behind our dreams. Behavior interpretation is also used to gain insight into why people behave the way they behave and to help resolve these conflicts and their anxieties. Psychoanalysis is lengthy. It requires weekly sessions for several years. It's not anything that resolves overnight. It can be expensive, and even though it is practiced today, it's practiced on a limited basis. It is usually very costly, and health insurance does not pay for it. At one time, it used to be considered therapy for the wealthy because only the wealthy could afford it. And then Freud, it does have the basis of Freud's defense mechanisms. They still believe that in their current treatment. So next, we're going to talk about Jean Piaget and Erik Erikson. You guys probably remember these people from your psych class. Did you guys have to take psych to get into the LPN program? Or if you were in the nursing program, you probably took it. So they were responsible for developing developmental theories. So Erik Erikson, he extended on Freud's work on personality development in life stages, and he published what he called the 8 stages of psychosocial development. So according to his theory, in each stage, the person must complete a life task that is essential to him or her doing well. It contributes to their mental well-being. Completing these tasks will allow each person to achieve their life virtues. So he believes that life virtues are hope, to be able to find purpose, to practice fidelity, to be able to love, to be able to care, and to have wisdom. His theory also believed that psychosocial growth occurs in sequential phases, and each stage is dependent on completion of the previous stage and life task. So if you don't complete one phase or stage successfully, you won't ever move into the next phase. And there's more about that in your book, table 3.3. So there is an example in your book that they give about this developmental theory. So it gives the example that in the infant stage, which we consider between birth and 18 months, there's this trust versus mistrust. So the infant has to learn to develop basic trust, right? Which is for them a positive outcome, that he or she is going to be fed and that they're going to be taken care of. The formation of trust is considered essential. Mistrust, which would always be a negative outcome of this stage, will impair the person's development through his or her life. So this is a prime example of something that can happen in your childhood that you might not ever remember. So if you happen to be the child of someone who had parents that were not able to care for them properly at that time, and maybe you didn't get fed like you were supposed to, or you didn't get diaper changes like you were supposed to, and your basic needs weren't met, that this is going to impair your development later in life. All right, so Jean Piaget, he said that he explored how intelligence, along with cognitive functioning, developed in children. He suggested that individuals reach cognitive maturity by middle to late adolescence, and he thought that there were 4 stages. So the 4 stages are sensorimotor, which is birth to 2 years. Then he has pre-operational, which is age 2 to 6. Concrete operations, which is 6 to 12 years, and then formal operations, which is 12 to 15 years old and then beyond. So he believed that the nurse may better understand what the child means if the nurse is aware of that patient's cognitive development, which, based upon what we've learned already, such in this class, I would think that that's an accurate statement, right? Also, teaching for children is often structured within their cognitive development. So when we teach our older adults or our adult patients, that's one of the things we always say about educating them. We have to know what their education background is and their cognitive level so that we can tailor that education to them. So that development theory is something that we're still seeing in practice today. So this is Harry Stack Sullivan. He is responsible for developing some interpersonal theories. So he is an American psychiatrist who developed the theory of personality development, which included the significance of interpersonal relationships. So inadequate or non-satisfying relationships are known to produce anxiety, which he saw as the basis for all emotional problems. So if we don't have good working relationships with our friends, our coworkers, our family members, this is what is going to cause all of the emotional problems that a person has. So he believes that there are 5 life stages. So he believed in infancy, childhood, juvenile, pre-adolescence, and then adolescence. He also had 3 developmental cognitive modes. He believed that mental disorders are related to the persistence of one or more of the early modes. So the first one is prototaxic, which occurs during infancy and childhood. This involves the brief, unconnected experiences that have no relationship to one another. They're unconnected. It also believes that adults with schizophrenia exhibit persistent prototaxic experiences. Then there's parataxic, which we start to see early in childhood. This is where the child begins to connect experiences in sequences. And the child may not make logical sense of experiences, and he may just see them as coincidence. Then there's the synaxic, which develops in our school-age children and becomes more predominant in that pre-adolescent age. This stage is where the person becomes to perceive him or herself and the world within the context of their environment. And they're able to analyze experiences in a variety of settings, whether they're good or they're bad. Again, you can read more about this on page 46, table 3.4. The significance of interpersonal relationships. There is, he believed in therapeutic community, or the milieu was viewed as the goal of treatment as an establishment of satisfying interpersonal relationships. So he believed that those interpersonal relationships were extremely essential, and he believed in therapeutic community, that milieu setting. He believed that the treatment emphasizes the role of the client-to-client relationship. It involves clients interacting with one another, including practicing interpersonal relationship skills. So if you can improve the interpersonal relationship skills with other people, you can improve your mental well-being. And it allows giving one another feedback about certain behaviors and then working cooperatively as a group to be able to solve day-to-day problems. So that definitely is a theory that we still see today, especially in our rehab centers, long-term care treatments. They work in groups and milieus all the time. So this is Hildegard Papleau. She also had an interpersonal theory. So she talks about the therapeutic nurse-patient relationship, and we're really going to talk a lot about this through this course. She was a nursing theorist and a clinician. She took what Sullivan had wrote about interpersonal skills, and she added on to that. And she was able to recognize the importance of all the things that he talked about with that interpersonal theory, but also how important the role of the nurse was. And she developed the concept therapeutic nurse-patient relationship. So she believes that there are 4 important phases to developing this relationship. You have the orientation phase, the identification phase, the exploitation phase, and the resolution phase. So during the orientation phase, you are directed by the nurse, and it involves engaging the client in treatment. So you're providing explanations, you're giving the patient information, and you're answering questions. So this is just the start of the relationship. So you're telling the patient, this is what you're here for. What do you want to work on? What things are important to you? You're exchanging information, ideas, you're building that relationship, answering any questions that the patient has. Then you do the identification. So this is when the client starts to work interdependently with the nurse. So you've established what you think is important. Now you're going to start putting that into motion. So the patient's going to start expressing feelings, and then over time, they're going to start to feel stronger. And then exploitation, this is where the client makes full use of all the services that are offered. And then resolution, this is what we want each patient to have, right? We want their problems to be resolved. The client no longer needs professional services and gives up that dependent behavior. And when that patient gives up that dependent behavior, that's when the therapeutic nurse-patient relationship ends. She believed that the nurse's role is to meet the patient's needs. So offering the client the same acceptance and courtesy that the nurse would to any stranger. She believed that you needed to be a resource person, that you had to know you had to anticipate what your patient needed, and you needed to be able to contact people in the community, work with case managers to be a resource for that person and get them what they needed to be successful. You had to be a teacher, so you had to take on that role of educating your patient about certain things. Maybe it's their medication or different coping strategies. You have to be a leader, so you have to lead by example. And then a surrogate. So maybe in some way, for some patients, you are serving as a substitute parent or a sibling because you are with them every day. You're developing that trusting relationship. So that is how the patient may end up seeing you. And then, of course, you're also a counselor because you're providing and promoting experiences that are going to lead to a better health outcome for your patient. She defines anxiety as the initial response to a psychiatric threat. So she says that there are 4 levels of anxiety. So the first level is mild anxiety. So this is allowing the client to learn new behaviors and solve problems. So anxiety, when we feel it, is always going to cause us to respond a certain way. So if it's just mild anxiety, it's going to make us alert. And like it says here, we're going to probably learn some new behaviors and learn how to solve some problems. Moderate anxiety, so our anxiety is just a little bit worse than mild. Whoops. That's going to allow you to only focus on the immediate task only. You're not going to be able to, per se, look at that bigger picture. You're only going to be able to focus on that task. And then severe anxiety. So this is going to involve feelings of dread or terror. And then we have panic anxiety. So this is where any rational thought goes out the window. You might be having delusions. You could have hallucinations, and you could have some people, their anxiety is so bad that they're completely immobile and they're mute. Severe cases, obviously. So there are different anxiety levels. You can read more about that on page 48, table 3.6. So then we have what we call humanistic theory. So humanistic theories focus on a person's positive qualities and his or her capacity to change. So what are their positive attributes? What do they bring to the table? And to what capacity are they even capable of changing? And then the promotion of self-esteem. It directs more attention towards the present and the future than looking back. So Abraham Maslow, he was one of the people that created a humanistic theory. So he studied the needs or motivations of individuals. So what motivates us? What keeps us going? What makes us strive to do better? He focused on the total person, not just one facet of the person. And he emphasized health instead of simply illness and problems. He formulated what we know now as the hierarchy of needs. He used a pyramid to arrange and illustrate the basic drives or needs that motivate people in almost every situation in life. His basic physiologic, safety and security, love and belonging, esteem, and then self-actualization are all the things that are on that pyramid. If you can meet all those needs in that triangle, then he believes that the client has developed his or her fullest potential in life. He also believed that few people ever become fully self-actualized. The basic needs are at the bottom of the pyramid, and they dominate the person's behavior until those needs are met. And then when those needs are met, the next level would become the dominant level. So this is Abraham Maslow, and these are our hierarchy of needs. So our physiological needs are at the very bottom. These are our basic needs that dominate us the most. So these are food, access to water, warmth, rest, having a home. Then next comes our safety needs. So this comes with us being able to feel secure and feeling safe. Then we have a psychological needs. So these are our belongingness and our love needs. So do we have intimate relationships? Do we have friends? Are we able to give love and feel love between other people? And do we feel like we belong? And then also in our psychological needs is our self-esteem needs. And this is prestige and a feeling of accomplishment, which a lot of people struggle with. And then at the very top, this is our self-fulfillment. So this is self-actualization, which means that you are achieving one's fullest potential, including creative activities. But according to him, he says that very few people actually reach this top part of the pyramid. So Carl Rogers was also responsible for creating a humanistic theory. His focus was on the therapeutic relationship, and he developed a new method of client-centered care therapy. So if you think about all these so far that we've talked about, basically these other people, you have this initial person who started this theory, but then these other people come behind them and they basically build on what they've thought, okay? So they're not recreating the wheel, they're just doing a little bit more work and adding a little bit to them. So he believed that you first have to use the term client rather than patient, which if you guys have, if you've noticed in your book, our book refers to client more so than patient, which is just a complete switch from when I was in nursing school only 7 years ago. We always referred to the patient as the patient, and that's still, those terms are still used interchangeably, but your book does say the client. And this is what he believed, that they should be a client rather than a patient. He believed that client-centered therapy was a focus on the client's role as the key to the healing process. So he was a big advocate for client-centered therapy. He believed that clients do the work of healing, and within a supportive and nurturing client-therapist relationship, clients can cure themselves. He believed that the therapist is responsible for promoting the client's self-esteem as much as possible through 3 central concepts: unconditional positive regard, genuineness, and empathetic understanding. He also believed that the basic nature of humans is to become self-actualized or to move towards self-improvement and constructive change. So when we talk about unconditional positive regard, this is expecting that the nurse has a non-judgmental, caring attitude for the client that is not dependent on the client's behavior. So you might have a patient who is going through alcohol withdrawal or maybe some type of drug withdrawal. They might be presenting behavior that they wouldn't normally present on any regular day because they have something really major going on with them. So this would require you as the nurse to be able to see past the problem that they're having at the current time and still provide care for them in a non-judgmental, caring way. Okay, so doesn't matter how the patient acts, you're still not going to judge them and you're still going to give them the best possible care that you can. That the nurse should always be genuine. So you should be real, practice congruence between what the therapist feels and then what you say to your client. And then you should have empathetic understanding in which the therapist senses the feelings and the personal meaning from the client. And then you can communicate this to understanding the client. So this is Carl Rogers. This is his little pyramid, very similar to what we saw with Maslow. So our physiological needs are at the bottom: food, water, and sleep. Safety is second, home sweet home. Then we have love and belonging, same thing, achieving deeper, more meaningful relationships, feeling like you belong somewhere. Esteem, he believed that you're required this skill that leads you to honor and recognition. And then self-actualization, you're living to your highest potential. So some of our behavioral theories, Ivan Pavlo, he was responsible and well known for his classical conditioning. You guys might remember this from psych if you took that course. So behaviorism, he believes, focuses on behaviors and what one can do externally to bring about behavior changes. It does not attempt to explain how the mind works, like some of these other theories try to go into what's going on in the mind. How does the mind work? How is it affecting the things that people do? This does not take on that attempt at all. Behaviorists believe that behavior can be changed through a system of rewards and punishments. So Ivan Pavlo did the classical conditioning. He had an experiment with dogs that involved his observation that dogs naturally begin to salivate, which is a response when they saw or smelled food related to a stimulus. He set out to change this salivating response or behavior through what he called conditioning. So he had a dog, the dog would ring the bell. Okay, ringing the bell was the new stimulus. When the bell would ring, it would produce food, the dog would salivate. This was the desired response. So eventually over time, he could ring the bell and the dog would start salivating without even seeing or smelling the food. So based upon this experiment, he considered that the dog had been conditioned. So then he thought you could do this.
You like what's on the end.
Oh, sorry. Yep. So then he believed that you could do this. If you could do it with an animal, then you could do it with humans. Then we have B.F. Skinner. He also had a behavioral theory. He developed the theory of operant conditioning, which believes that people learn their behaviors from their history or their past experiences, particularly those experiences that were repeatedly reinforced. Principles of operant conditioning form the basis for behavior techniques in use today. So he believed, there's 7 of them. Number 1 is that all behavior is learned from a past experience. It is a consequences result from behaviors, broadly speaking, reward and punishment. Behavior that is rewarded with reinforcers tends to reoccur. Positive reinforcers that allow a behavior increase the likelihood that behavior will in fact reoccur. Negative reinforcers that are removed after a behavior increase the likelihood that the behavior will reoccur. Continuous reinforcement, so it's a reward every time the behavior occurs, is the fastest way to increase that behavior, but the behavior will not last long after the reward ceases. And then random intermittent reinforcement, an occasional reward for the desired behavior, is slower to produce an increase in behavior, but the behavior continues after the reward ceases. So I think a couple of these principles we've probably all used in our life. If you are an employee or if you happen to be an employer, you take care of other people. If you're a parent, if you've ever trained a dog, we can see some of these behavioral theories. Training dogs is way easier than training kids, just saying. Behavioral theories and behavioral modifications. So there are a couple treatment modalities that we think about when we think about behavioral theories. One is behavior modification. So this is a method that we use of attempting to strengthen a desired behavior. So a behavior that we want and that we want to see again, or a specific response that we want to see again by reinforcing it, either positively or negatively. We have positive reinforcement. So if the desired behavior is assertiveness, whenever the client uses assertiveness skills in a communication group, the leader gives the client attention and positive feedback. When we think about behavior modification, and we talked about either positive or negative. So if we have a toddler that goes to, like my granddaughter, God, she is just a no-limit soldier, God live her. She's so cute, but she's 4 years old and she's like a bully sometimes when she goes to school, and she will actually hit the other kids if they don't want to play with her. So my daughter will say, on Monday, she'll say, if you can go all 5 days without hitting anyone in your class, then you get a treat at the end of the week. So that's a positive behavior modification. And if she does hit anyone, then she has to go to bed at night without her tablet. So that's where we come up with the positive or the negative. We use each one to help modify that behavior. Then there's negative reinforcement. So this involves removing a stimulus immediately after a behavior occurs so that the behavior is more likely to occur again. And then we have continuous reinforcement. So this is what they think the fastest way is to increase behavior. Random intermittent reinforcement increases behavior slowly, but then we're going to see it last longer. We have what we call token economy. So this is a way to involve the client in performing activities of daily living or an attention deficit hyperactivity client disorder. It helps them complete tasks at home or school. So this would be a chart, a motivational chart. So if you, every day when you complete your chores or every day when you put your homework binder back in your folder and you put your book bag by the front door, you get a check, okay? So you get a check or a token or some kind of a slip that gives you a reward if you meet a certain, whatever you set up, whatever the behavior is that you're trying to manage. And then we have systematic desensitization. So this is used to help clients overcome irrational fears and anxiety. It helps clients learn and different practices to relaxation to help decrease and manage anxiety, because a big component to mental health is that, yes, we can give them medications that help calm their anxiety or help them think a little bit different, but we also have to have these behavioral modifications. It's, a two parts to the therapy. Then we have extensional therapies, so theories. So these are the overall belief theory. So this is a belief that behavioral deviations occur when a client is out of touch with him or herself or their immediate environment. It believes that the client is lonely and sad and feels helpless. There is believed to be a lack of self-awareness coupled with harsh self-criticism. They believe that those two, the lack of awareness and the criticism, prevent the person from participating in satisfying, healthy relationships. The goal is that we will be able to return the person to an authentic sense of self. They're going to have a better self-esteem. They're going to think better about themselves. We want to encourage that client to live fully in the present, not look back to things that they haven't done well or things that aren't going well. And we want to be able to look forward into the future and emphasize personal responsibility for their self, for their feelings, their behaviors, and their choices. And then we have cognitive theory. So this focuses on immediate thought processing. So how a client perceives or interprets him or herself, their experience, and determines how they feel and then how they behave. And this is the cognitive therapy. This is the most, the therapy that we've seen used the most in existence today with therapists that practice today. So we have rational emotive therapy. This is developed by Albert Ellis. He believed that there were 11 irrational beliefs leading to unhappiness. He believed automatic thoughts that caused people unhappiness, and he developed the use of the ABC technique to help identify these thoughts. So A is activating a stimulus or an event. B is the blank in the person's mind that he or she must fill in by identifying the automatic thought. And then C is the excessive inappropriate response. Then there's logotherapy, which was developed by Viktor Frankl. He observed people in Nazi concentration camps during World War II. He was curious about why some survived and some didn't. He believed that survivors were able to find meaning in their lives, even under the most miserable conditions, and that they could focus on the future and make it through another day. Then there's the Gestalt therapy, which was developed by Frederick Fritz Perls. which had an emphasis on self-awareness, which eventually leads to self-acceptance and responsibility for one's own thoughts and feelings. It practiced on the identification of thoughts and feelings that are in the here and the now. So not those present thoughts about what happened before, what bad things you experienced before and how they're affecting you today. Then we have reality therapy, which was developed by William Glasser. The focus was on a person's behavior and how that behavior keeps a person from achieving their life goals. He believed that people who were unsuccessful often blamed their problems on other people, the system, or society. He believed that they needed to find their own identities through responsible behavior and being accountable. So crisis intervention. So there are some people who experience mental or who have mental health issues that at some point will require an intervention, and it's considered a crisis. So a crisis is what we call a turning point in an individual's life that produces a very overwhelming emotional response. There is said to be 4 stages of a crisis. So the person first is exposed to a stressor and experiences some type of anxiety, and they try to cope. The anxiety increases when usual coping skills are ineffective, or if they don't have coping skills. An increased effort to cope, they will try to develop new methods of coping. And for some people, that will turn into drugs or alcohol. And then our coping attempts fail, and the client experiences a disequilibrium and significant distress. So there are different categories of crises to a variety of life situations and events. So there's maturational category, which is a predictable event in the normal course of a life. So these are things that bring us some type of stress. So getting married, having a baby. So these are good things. These are good things that we want to experience in life, but obviously they come along with some type of stress. It's for some people, they might have a stressful pregnancy, or their pregnancy might be great, but then they're having a hard time adjusting to only getting 45 minutes sleep a night. Same thing with getting married. There's a lot that goes into getting married, a lot you have to plan for. It's a big financial expense. Then we have situational. So these are unanticipated or sudden events that threaten the individual integrity. So when we lose our job, when we lose a child, a mother, a father, a sister, any loved one that we lose, that's considered situational. And then we have adventitious, which are social crises. So this is our natural disasters. So hurricanes, tornadoes, terrorist attacks, violent crimes such as rapes, murders, things like that. And then we have not all events that result in crisis are negative, right? We talked about the marriage, retirement, childbirth. Crises are usually self-limiting. That is that they don't last indefinitely. The duration of a crisis is usually 4 to 6 weeks. The outcome is resolution to functioning at either the pre-crisis level, a higher level, or a low level. So when we talk about the pre-crisis level, this is a positive outcome for the patient. So you're going to return to the state that you were before you had this crisis. If you have this crisis resolution and you return at a higher level, this is also positive because you're better than you were before the crisis. And then if your outcome is a lower level, this is what we consider a negative outcome. So we don't want you to have a crisis and resolve to a lower level of functioning than you were before you had the crisis. And positive outcomes are more likely to occur when we can clearly identify the problem. Again, this is why some people, if you look at this, as crisis is being self-limiting, some people that don't have good coping skills don't always see that. They can't see past it. They can't see that it's not going to last forever. And then that's when they commit suicide and do other things like that. And then when we talk about these people that don't have coping skills, if they have drug addictions or alcohol addictions, they are usually going to come back at this lower level. And that's a negative outcome because their problems are never clearly defined. They never find out what's bothering them, why they can't cope, so they can't fix the problem. So they continue to self-medicate through alcohol or drugs. So there are different crisis intervention techniques. The nurse must be able to focus on the patient's previous coping strategies in other situations and provide support to deal with the current situation. This is important. You guys need to know this, okay? So if you're going to help a patient focus on what they're dealing with now and offer them coping strategies, you need to be able to sit with the patient, talk with the patient, and talk about other things that they've dealt with in their life and what worked for them. Because if they dealt with something previously and they had good coping strategies, it's a good idea for us to take and hone in on those coping strategies and somehow tailor them so that they can use them in this situation. So it's important that you know what their previous coping strategies were. We have directive interventions, so we assess their health and that we promote problem-solving skills for them. So we offer the patient new information, knowledge, or meaning. We raise the person's self-awareness by providing feedback about behavior. We can, if you're dealing with someone who has a drug addiction, you're going to talk to them about being aware of their feelings, what causes them to think like this, what are their triggers, and then you want to offer suggestions or courses of action. So if you feel like you want to use, you need to, maybe enroll yourself in a 12-step program, reach out to your sponsor. These are the things that we would want to tell our patients. And then we have supportive intervention. So we're dealing with the person's needs for empathy and understanding. So we want to encourage the patient, the client, to identify and discuss their feelings. We serve as a sounding board to them. We sit, we be present. Sometimes we don't say anything. We're just actively listening and we're being present with the patient. So we build that trusting relationship with them and they feel like they can talk to us. If they feel like they can talk to us, they're going to open up and they're going to identify things that are bothering them and why they feel certain ways. And then we always, always, always want to affirm the person's self-worth. So that doesn't require you to affirm their behavior. You don't, if you're taking care of a patient who is addicted to some type of a substance, you don't have to affirm or give any type of positive promotion to the drug abuse or the alcohol abuse, but you can tell them, you are worthy of having better. You are a great person. You have so many people in your life that love you, that are supportive of you. So you have so many, you have this quality or that quality. You always want to tell them what their self-worth is so that they are capable of feeling better about themselves. Some of our major psychosocial theorists that we talked about tonight, they were white, they were born in Europe or the United States, and they seldom treated out of their cultural populations. So what they considered normal or typical may not apply equally well to people with different racial, ethnic, or cultural backgrounds. So that's important to understand with all of these theories that we talked about tonight. You guys want to take like a 5-minute break before we do the rest of our slides? Or do you want to keep going?
Doesn't matter to me, whatever everybody else wants.
You just want to keep going? Okay, we're going to keep going since nobody answered.
Yeah, keep going.
Okay, so treatment modalities. So inpatient treatment is often the last rather than the first mode of treatment for mental illness for various reasons. For one, it is more beneficial and cost-effective for clients to remain in the community and receive treatment in an outpatient treatment center. For inpatient treatment, it is very costly. Insurance companies do put that limit on it, that cap of how many inpatient services you can have. Some of them don't cover it at all. And we quite honestly don't have the beds in the hospital settings to be able to house all the people that need inpatient treatment. So inpatient treatment is always for severe crises, people who can't function in the community effectively, people who are threaten to commit suicide, harm themselves or others. So community mental health treatment, this is the primary mode of treatment. It works to help clients continue to work. So they're going to work every day, they're being productive members of society, they're able to stay connected with their family, their friends, and they have other support systems in the community. Personality or behavior patterns gradually develop over the course of a lifetime. They are unable to be changed in a relatively short inpatient course of treatment, which is why we see so many readmissions to hospitals, because it's the same thing with losing weight. You don't just gain weight over a month, this huge amount of weight. It's always a gradual onset over a period of time. Well, it's the same thing with losing weight. You're not going to lose it overnight. It's the same thing with mental health. We can't fix you in a month or 45 days. It takes a long time. There's peer counseling, advocacy, and mentoring that are showing very positive results. I know in my facility, we have something which is great. It's in our emergency department. We have people who we call peer counselors or mentors. They stay there and they talk with our patients who are suffering with alcohol addiction and drug addiction, and they will come to the different units and meet with our patients and help them get into programs, and they are recovering addicts themselves, which I think is phenomenal, because they walk the walk, they talk the talk, they know it, they've done it. And I feel like a lot of people suffering with these issues always take the advice of someone who has been in their shoes, because they can really relate to them. So these are great strategies, and I agree that they are definitely showing positive results. I don't know if other emergency rooms have them, but our hospital definitely does. So hospital inpatient treatment is often, like we said, the last mode of treatment. Indications for an inpatient hospital stay are going to be severe depression, suicide, severe psychosis, alcohol or drug withdrawal, mainly alcohol withdrawal. So when we talk about addiction, we'll talk more about this, but alcohol withdrawal can kill you if you're not in a hospitalized setting. Drug withdrawal, you're going to be very angry and probably really sick, throwing up and vomiting, but it's not necessarily going to kill you. Alcohol withdrawal can. Behaviors that require close supervision in a safe, supportive environment. These are all indications for that hospital inpatient treatment. We have individual psychotherapy. So this is a method of bringing about a change in a person by exploring his or her feelings, talking about their attitudes, why they think the way they do, and why they behave the way they do. It involves more verbal therapist to client interaction than what they consider the classic psychoanalysis. The client and the therapist develop that trusting relationship, which enables them to explore the client's problems. It is a one-to-one relationship between the therapist and the patient that is confidential. And it obviously has a progression through stages. So the more you meet and the more you build that nurse-client relationship, the more progress you're going to make. Both the client and the therapist must be compatible for therapy to be effective. So this is also another deterrent for people in the community setting. You have to believe in the person that you're talking to, and you have to have, I think, like I say, a connection with these people in order to be able to open up and see them on a weekly basis or a bi-weekly basis. So if you don't like the therapist that you're seeing, you're not going to go back to them. And that's the problem that a lot of people experience. They finally get an appointment with someone. It's really hard to just get a mental health appointment, especially now with COVID. You're on waiting list for a long time. You finally get that appointment, and then you meet someone who you're not compatible with and you don't care for. So then you're just like, forget it. It's not even worth it. I'll just deal with my issues. I don't even need a therapist. I'm never going to find the right one. These are things that people say. And then a therapist's theoretical behaviors or beliefs strongly influence the style of therapy they have, which also can cause incompatibilities. So the client must also have to try a different therapist to find a good match. Not everybody's willing to do that. And the client should select a therapist carefully and ask about the therapist's treatment approach and the area of specialization. And quite honestly, a lot of patients that need mental health don't even know about various treatment approaches. They might understand areas of specialization, but they don't really know about the different treatment theories that there are. So we have group and group therapy. Group is a number of people who gather in a face-to-face setting to accomplish tasks that require cooperation, collaboration with each other, or working together. So it usually includes a therapist or a leader, and then a group of clients that share a common purpose. Members in the group contribute to the group with the expectation of benefiting from it. They're all going to learn something from each other or the therapist. So there are different stages of group development. So we have the pre-group stage, which is where members are selected and the purposes of the group are identified and the structures of the group are addressed. Then we have the beginning or the initial stage. So this is where the group begins to meet. They all discuss the purpose of the group, what they want to accomplish, and then the rules or any expectations are reviewed. The working stage, this is where the members must develop some level of trust. So if you don't trust the people in the group, you're never going to want to share your feelings or talk about different uncomfortable situations. If you feel like you're being judged and people are mocking you, it's never going to be successful. So you have to be able to develop some level of trust. And then lastly is determination. So this is where the work of the group is accomplished and the work is reviewed. Group leadership, this is a face-to-face setting to accomplish tasks that require, again, cooperation, collaboration between each other, and it makes them work together. The formal leader is usually for therapy groups and education groups. The informal leader is usually for support groups and self-help groups. A formal leader is usually identified based upon his or her education, their qualifications or experiences. So that's the difference. The focus is on group process, group content, and that's the two focuses that you need in order for that therapy to be effective. So group content refers to what is said in the context of the group. So what are you guys discussing? Group process refers to the behavior of the group and the individual members. Content and process occur continuously throughout the life of the group. The tasks of a group leader is to help encourage participation from all members of the group. They work to clarify each group member's thoughts, their feelings, and their ideas, and then they summarize progress and accomplishments within the members of the group. Group roles. Roles are parts that members play within the group. So some roles facilitate the work of the group, while others can negatively affect the process or the outcome of the group. So growth producing roles that you will see in groups are the information seeker. So the person that always wants to have more information. Knowledge is power. Then you have the opinion seeker, the information giver, the energizer, the person who coordinates everything, the harmonizer, the person that always has the positive, happy attitude, the encourager, so someone who's always encouraging to everyone, and then the elaborator. So those are things that all produce growth within a group. Things that you would see.
Davis, can you let Sophia in, please?
Yes, thank you. Growth inhibiting roles that you would see are someone who's a monopolizer. So someone who always makes it about them, someone who's always talking about them and not giving anyone a chance to talk. You have people who are the aggressor. So when you're talking about fragile topics, they always get aggressive. They want to start fights. The dominator, similar to the monopolizer, always has to dominate the conversation. The critic, that's the person who is very critical of other people who think that they do no wrong. The recognition seeker and the passive follower. Those are all things that inhibit growth in a group. So therapeutic results of group therapy, what do we want to accomplish? Well, we want to gain new information or learning, right? And you want to be able to gain inspiration or hope. You want to be able to have good, healthy interaction with other people. You want to have feelings of acceptance or belonging. Everybody wants to feel like they're accepted and that they belong, regardless of what they've dealt with or what problems they have. We want them to have an awareness that they're not alone and that they share the same problems that other people do. We want to have insight, and they want to gain insight into their behaviors, their problems, and their effects on others. And then you want them to experience altruism, which is giving of oneself for the benefit of others, which is what nursing is. So what types of therapy groups do we have? There's psychotherapy groups, where this is where members learn about their behavior and they learn to make positive changes in their behavior by interacting and communicating with others. There's family therapy. These therapists focus on the needs of the family and problems within family dynamics. So husbands and wives, so maybe marital counseling or family counseling with parents and their children. Family education. These discuss the clinical treatments of illnesses, and they teach the knowledge and skills to their family members that they need to be able to cope more effectively, and then to be able to provide care for that loved one when they go home. There's different education groups. So these groups focus on providing information to members on specific issues. So stress, medication management, things like that. Then we have support groups, which are organized to help members who share a common problem and offer potential solutions. So these are patients who suffer from cancer, patients that have had strokes, patients that suffer with AIDS, people who have been who have experienced suicide of a loved one, and then MAD, which is Mothers Against Drunk Drivers. And then we have self-help groups. So these self-help groups have very strict rules of confidentiality. So when these groups are held, whoever is seen at these meetings and whatever is held cannot be divulged to other people, and it can never be discussed outside of the group. So these groups are your Alcoholics Anonymous and your Narcotics Anonymous. So, of course, we have complementary and alternative therapies. So the National Center for Complementary or Integrative Health is a federal government agency for specific research on complementary and alternative medicine, CAM. Complementary medicine includes any therapies used with conventional medicine practices. Alternative medicine includes therapies that are used in place of conventional treatment. Alternative medical systems, that's going to be your homeopathy, traditional Chinese medicine, herbal and nutritional therapy, yoga and Tai Chi. There's also medication, and then acupuncture. Then we have mind-body interventions, so your meditation, prayer, art and music therapy, and then biologically based therapy. So these are going to be your herbs, your vitamins, your aromatherapies, medicinal teas, and certain health foods. You also have manipulative and body-based therapies, so therapeutic massage, chiropractic manipulation. We have energy therapies, so biofold therapies. These are used to affect energy fields that some people believe surround our bodies and penetrate our bodies, such as therapeutic touch, Qigong, and Reiki. Then there's bioelectric-based therapies. These involve the unconventional use of electromagnetic fields, such as pulsed fields, magnetic fields, and alternating currents or direct current fields. Some nurses should understand that some clients may be reluctant to tell the psychiatrist or primary care provider about the use of CAM. They might be embarrassed because it's not something that's traditionally used. It might be something that they believe in and they're afraid that the therapist might not condone it. Whatever the reason is, some people are just very reluctant to telling the therapist. So it's important as the nurse that you ask the client specifically about the use of herbs, vitamins, and other healthcare practices that they may have in a very non-judgmental way. All right, that's important. You guys need to know that. So these are some of the complementive and alternative therapies, those bioelectric therapies, the Qigong, therapeutic touch. We also have psychiatric rehabilitation. So these are services to patients that exhibit persistent severe mental illness. It helps them to be able to live effectively within the community. It's also known as community support services or community support programs. These focus on the patient's strengths, and they're designed to help the client manage their illness and their symptoms while gaining access to services that they need. And between the combination of managing their symptoms and giving them access to needed services, it is hoped that we will allow them to live successfully in our community. There are activities involving medication management, transportation. So some people require medication that they need on a weekly basis. Some people don't have transportation. So we make sure that if they can't get to their medication, that we get their medication to them. We give them transportation to therapy, helping them shop for their groceries, helping them with food preparation, self-help at home, like hygiene, cleaning their house, helping them with their finance, giving them that social support, and then helping with vocational referrals. So all those things, if we can help them gain access to these things, they can live those productive life in society. Psychosocial interventions, these are nursing activities that enhance the patient's social and psychological functioning, and they promote social skills. They help promote positive interpersonal relationships and communication. They're used in mental health and other practice areas as well. So self-awareness issues. So we said before, it is the nurse's responsibility to support the client's needs and goals. We do not, as the nurse, promote the nurse's ideas about what we think that the client should do. No one theory or treatment approach is effective for all patients. First and foremost, you have to remember that. What worked for one of your patients probably will not work for another patient. Using a variety of psychosocial approaches will increase your effectiveness as a nurse. The patient's feelings, their perceptions, most influential in determining his or her response to therapy. So treatment settings and therapeutic programs. So different treatment settings, we have inpatient hospital treatment. They have access to rapid assessment, stabilization of symptoms, and discharge planning. You have client-centered multidisciplinary approach to a brief stay. Short inpatient stays, this is what we're seeing now. The trend is to move away from them inpatient stays and towards the use of alternatives to hospitalization. So those community outreach programs that we have in place, those are alternatives to having patients be inpatient in the hospital. So inpatient hospital treatment, long stays for severe persistent mental illness requiring acute care services. Those are the patients that are approved for inpatient stays. We have case management. So case management usually happens, it's a nurse or a social worker who are going to follow that client from the minute they're admitted to their discharge, and they serve as liaisons between the client and their community resources. So what are they going to need when they return home? Are they on medications that they need weekly? We need to find a close place to where they live. Where are they getting their prescriptions? Do they have a way to get there? Do they have an injury or a wound that needs tending to? So we have to set up home care for them, and then any third-party payers. Discharge planning. These are always based on the individual's needs. Discharging planning starts the minute the patient gets admitted into the hospital. Not that we're in a rush to get them out, but sometimes it takes a while to anticipate all the needs that they have. So it's a process that we want to start as soon as they are admitted into the hospital. It includes medication management. It includes anticipating any educational needs that they're going to have. Timely outpatient appointments, you want to make sure that if they need to have follow-up appointments, what we like to do is schedule those appointments ahead of time before they're even discharged. We let them know at the time of discharge. In their discharge instructions, you're going to follow up with your primary on this day at this time. You're going to go to your outpatient services at this location on this date at this time. And then we always follow up with a phone call after they've been discharged to make sure that everything is going smoothly and that they're getting everything that they need. It is an essential component is relapse prevention or early recognition of relapse. So you need, this is another reason why if we have patients who are suffering from alcohol abuse or drug addiction, when we have them in the inpatient setting, we like to keep them there until we have a treatment program that will take them, because it's highly unlikely that if the patient says, oh, I'm good, I can go home, I'm going to go to therapy at the end of the week. Well, some people don't make it to the end of the week. My realtor friend that I've grown up with most of my whole adult life, she had a daughter. We had children the same age. Her daughter was in and out of therapies for years, even went to jail, could not get away from the drugs no matter how hard she tried. She lived in Florida for a couple years. She came home to her mom. She said, I want to come back home. I want to go into a treatment program here. She tried to get her into a treatment program. She couldn't. It was a week out for a wait. During that week, her daughter overdosed and died. She never made it to that treatment program. So for one, it's hard to get into these treatment programs. A lot of people lose their lives because there are not available beds. And two, if we let them out, they don't have the coping skills or the strength to be able to follow through. They revert back to those bad behaviors. So it is an essential component to preventing that relapse, making sure that they have everything that they need in the outpatient community setting. We have partial hospitalization programs. So these programs are designed to help clients make a very gradual transition from being inpatient to living independently, and it helps prevent repeat admissions. They have day treatment programs where each client has an individualized treatment plan and goal, but they go to a treatment program every day, usually 5 days a week. And then there are 8 broad categories of goals. You can read more about them on page 65. It's box 4.1 in your book. They have residential settings where people live. A good example of a residential setting is a halfway house for patients who have alcohol and drug issues. They vary in structure and the level of supervision that's there and the services that they provide. But you can have group homes, you can have supervised apartments, you can have board and care homes. There's assisted living for people who require a little bit higher level of care. There's adult foster homes for people who are homeless. And then there are respite crisis housing care. So respite can be for the family members and also the patients. So for some patients that have chronic illnesses and they have family members who are taking care of them, it can be extremely overwhelming, and it leaves the patient at risk for being abused, not intentionally, but because their condition is so multifaceted and it can be a burden to their loved one. So we have these respite cares where you can take your loved one and put them there for a week or a week and a half, and then it allows a structured environment for them. They're getting the care that they need to keep them safe, but you also can have a break to go on vacation or to just have a well-needed break. That's what respite care is. So we have residential settings that are starting to evolve into the consumer household. We have group living situations. We have residents that make transitions from group homes to residences where they fulfill their own responsibilities and they function without on-site supervisors. So halfway houses work like this in a sense that they are able to go to work every day. They have their own room. They're responsible for paying their room and board, and they have certain duties in the house that they are required to fulfill. Most of those have on-site supervisors. There's usually a house manager because you have to have drug tests and things like that, but there are some in other states where you don't have that group supervisor. You live in an apartment with other people and you just check in when you go to your group therapy during the day. Then there's transitional care. So these are your peer supports, which are provided by a consumer now living successfully in the community. So a good example of that are the people that I have that work in the emergency room at our hospital. They offer peer support. So they have been drug addicts or alcoholics at some point in their life. They are recovering and they are living successful lives, and they can offer support to those who are still suffering. Then we have bridging staff, which is an overlap between a hospital and community care. It is hospital staffs, they do not terminate that therapeutic relationship with the client until that patient gets established in the community and they're able to develop another therapeutic relationship with another care provider. So that nurse stays with them until their feet are completely on the ground and they feel good with a new provider. So there's never any lapse in care, which I think is great. Because that's when you see those readmissions when they have that lapse in care. We have psychiatric rehabilitation and recovery programs. These are designed to promote recovery processes. The emphasis is on recovery, going beyond the symptom control and medication management, and it includes a lot of personal growth. It offers reintegration into community, usually on a staggered level. It gives the patients, it empowers them, it increases their independence, and it improves their quality of life. There is something called the clubhouse model, which is based upon the belief that both men and women with serious and persistent psychiatric disabilities can and will ultimately achieve normal life goals when they have the opportunity, the time, the proper support, and the proper fellowship. There are 4 guaranteed rights of the models that participate in this program. They always know that they have a place to come. No matter what, this is a safe place for them. They will always have meaningful work available to them. They will always have meaningful relationships with other people that are in this model. And they always, regardless of the time that has been since they've needed help, they will always have a place to return. It's a lifetime membership. There is a physician-client relationship that is key with this model, and the focus is on health, not illness. They have assertive community treatments or ACT. It is one of the most effective approaches that we see today. It looks at problem solving. They don't believe that any problem is too small, none is too big. There is a direct provision of service rather than referral. Services can be intense. They don't offer any time constraints, but it is not considered lifelong. Recovery programs, go beyond symptom control and medication management. There's another component to it. So for instance, with the NA and the Alcohol Anonymous, they do have medication that some of them take, but their recovery goes beyond that. So they work a 12-step program. So they go through a series of steps that they repeat sometimes over and over again. They complete these steps throughout their lifetime. They go to these meetings well after they're not suffering with this issue anymore. They believe they're always an alcoholic and they're always a drug addict and they're always a recovering addict. So they need these programs to stay on the path of success. But they get that personal growth and that reintegration into community, and they are empowered because they're surrounded by people who have the same issues as they do. They're realizing more about themselves because they're working these steps. They will get an increased independence as they start to make strides, and they will see an improved quality of life as their recovery process starts to take off. There are higher level goals and expectations that are characterized in later stages of recovery. And these recovery programs create and manage the change for the individual, staff, and throughout the organization. So homeless and the mentally ill. So in comparison to homeless, not mentally ill, they spend more time in jail. They are homeless longer. They spend more time in shelters. They have less family contact, and they face greater barriers to gaining employment. They have a couple projects that have been developed to help them. They have the PATH program, which is a project for the assistant to transition for homelessness. So this program comes in, works with homeless people to help them find a home, maybe in a a more long-term home. So maybe not a homeless shelter, but they might live in group homes with other people. It gives them therapy, medication, it addresses their healthcare needs, and it ultimately helps them live on their own and find jobs and be successful. Then there's the Access Demonstration Projects, which is the access to community care and effective services and support. It enhances the quality of life of homeless people with serious mental disabilities through the use of services and outreach. So kind of the same thing. Prisoners, the rate of mental illness among the incarcerated is 5 times higher than the general population. Factors that place for placement in the criminal justice system are deinstitutionalization, a more rigid criteria for civil commitment. There's a lack of adequate community support, economization of treatment for mental illness, and then the attitudes of police and society, which is something that we can attest to. We see this every day on the news. Criminalization of mental illnesses. So this is the practice of arresting and prosecuting mentally ill offenders, even for misdemeanors. This occurs at a rate 4 times that of the general population in an effort to contain them in some type of institution where they might receive needed treatment. Barriers to successful community reintegration include poverty, homelessness, substance abuse use, violence, victimization such as rape or trauma, and then self-harm. Our active military and our veterans, so the prevalence of PTSD, which is post-traumatic stress disorder, and major depression is greater than their civilian counterparts. So we almost always commonly see increased rates of suicide. They are most likely to commit homicide, have injuries or injure other people, suffer physical illnesses, suffer from sleep disorders, develop substance abuses to alcohol and drugs, and they are more likely to have marital and family dysfunction. They are also more reluctant to seek treatment. As we discussed throughout the night, treatment might not be readily available. So when it is available, they're not interested in it anymore. They lose hope. There's stigmatizing that goes along with that. What are people going to think? They're going to think I'm crazy, I'm mentally ill. There's a lot of stigmatism around mental illness. And then sexual traumas are very widespread. We see it in both males and females. So we're going to talk again about the interdisciplinary team. So this team, the interdisciplinary team for mental illness, is no different than the one you see in the hospital setting. You're still going to have that pharmacist because the patient may be taking medicine. You're going to have the psychiatrist and the psychologist. So the psychiatrist, you are going to see weekly to talk about your issues. The psychologist may prescribe your medications. You're going to have a psychiatric nurse. You're going to have a psychiatric social worker. You might have an occupational therapist. They're going to work on occupational therapy, helps you with your bathing and your dressing and being able to do things in the outpatient setting. You might have a recreation therapist and then maybe a vocational rehabilitation specialist, because we do see issues with people keeping jobs and being able to find jobs that have mental illnesses. So that's an important role. So the interdisciplinary team, those core skills, we have to have good interpersonal skills. We have to, not only for our patients, but for each other, we have to have tolerance, patience, and understanding. Every person that has a role with our patient is just as important as yours. So the physical therapist, the housekeeper that's cleaning the room, the dietary who's bringing it, they are just as important as you are. Humanity, we have to have warmth, we have to have acceptance for our patients and our interdisciplinary team. We have to have empathy, and we have to be genuine. We have to have a knowledge base about mental health disorders. We don't have to know everything. I don't know everything about mental health. I've learned a lot in the 7 years that I become a nurse, but we do have to have some type of common knowledge, which is what we're teaching you. It's kind of like a nurse generalist. We have to have communication skills. We have to be able to communicate with other members of the interdisciplinary team for our patients, because we have to be able to advocate for them. We have to have personal qualities such as consistency. So we have to be able to be consistent with the care that we provide. We need to be able to meet the needs of our patients by consistently recognizing what they need and showing up at their room, giving them their medications, making sure they have their food. We have to be assertive, especially when we're advocating for our patients. Sometimes it requires us to be assertive, not disrespectful, but firm and assertive. And then we have to be able to problem solve, think outside of the box. We have to have teamwork skills, right? Because we're working with all these members of this interdisciplinary team. So we need to be able to effectively share ideas, support each other, and be able to collaborate for the good of the patient. And then we kind of have to have these risk assessment and risk management skills as well. So we need to be able to anticipate what kind of things do you think our patients are susceptible for once we put them out into the community. So if it's a patient that has alcohol issues or drug issues, well, you know they're at a high risk for relapsing. So based upon what you've seen taking care of them, you need to kind of do a risk assessment and say, hey, what do I think is going to happen with this person if I let him go? So if you have a person who doesn't have anyone in the community, if he's from another state and he doesn't have his parents with him, he doesn't have a good support system sending him home, he's probably not the type of person you want to put back in the community. You might want to recommend that you keep him here until he has an inpatient placement somewhere so that he doesn't run the risk of relapsing. So we call that risk assessment and risk management. So psychosocial nursing in public health and home care, we talked about this early on in fundamentals. We have that primary prevention. Well, a good example of primary prevention is stress management and education. So we're trying to prevent things. We're not taking care of things that have already happened. We're preventing things from happening. Then we have secondary prevention. So these are being able to early identify mental health problems early before they get out of control. Then we get to these tertiary prevention. So now we're monitoring and we're coordinating psychiatric rehabilitation services. So now we have the issues. So now we have to monitor them and take care of them. And then our clinical practice issues such as substance abuse, domestic violence, child abuse, grief, depression. There's a lot of other ones that we will see if you have a job in public health and in the hospital as well, because you're dealing with the public. And then lastly, wait a minute, did we talk about this? Yep, sorry, I thought I missed a slide. Self-awareness issues. So evolution of care, we said, is moving from those inpatient settings into the community. And we said that they need to be client-centered in order for them to be effective, which includes improved quality of life and recovery from mental illness. That is our goal. There are non-traditional settings such as jails or homeless shelters that do offer these services. It empowers clients to make their own decisions. It is a very essential part of full recovery that they have self-awareness and self-confidence that they can make these empowering decisions in their life. It is a challenge for the nurse to be supportive when the nurse believes that the client has made choices that are less ideal, and frustration of working with clients having persistent and severe mental illness. So I will say that when I work with patients that have alcohol issues or drug addiction issues, they can be very mentally overwhelming. And I don't say that because I'm prejudiced or that I look down on those, because I've dealt with addiction in my own family. Firsthand, my oldest daughter, who by the grace of God, is going to celebrate 5 years clean in a couple weeks, but she was a raging heroin addict, lived on the streets in Highlandtown on Conklin Street for months because I wouldn't let her in my home because I wasn't an enabler. By all intents and purposes, she should be dead today. So I feel like more than most people, I am very understanding of them, and I understand why they are the way that they are. But it doesn't mean that they're not draining, and it doesn't mean that it's can't be a challenge for you when providing care for them. And it doesn't mean that you have to support the decisions that they've made. It just means that you have to be, you cannot provide care that's judgmental. You have to be non-judgmental. But that's part of self-evaluation and self-awareness, is that you recognize these things that bother you. So I know if I'm dealing with someone, especially people that have drug addictions and alcohol addiction, they are very, very manipulating and draining, because they will do whatever they can to get what they want. That's the addiction in them. It's not the person they are, it's their active addiction. And that can be very draining. And after one day, you don't even want to come back to work the next day. So if you guys experience that as a student nurse or in your practice, I want you to know that it's okay to feel like that. You just have to be aware of those issues and make sure that you're not projecting those onto your patients. There's frustrations that come along with any type of, even if you're not working with patients, even if you're working at Panera, there's going to be frustrations, and those are valid things. So I want you guys to understand that. That's an important part of being a nurse, because sometimes I hear nurses say, I'm not cut out for this. I'm not a good nurse. I feel this way. That's not the case. You are a great nurse. It's just that some things can be very draining. All right. So that's it. We're done. Your first week. I feel like some of this stuff is kind of boring at first. We'll get into the good stuff probably by week 3 or week 4. I feel like it's just more interesting, but we got to cover all this background stuff first. So who has questions?